Good evening, everyone. AAFA New England welcomes everyone to our speaker series event this evening. My name is Amy Dow. I am the Director of Education Programs for the Asthma and Allergy Foundation of America, New England chapter. We are a 501c3 nonprofit organization dedicated to improving the quality of life for people with asthma and allergies in the 6 New England states. At AAFA New England, we pursue our mission through a wide range of education programs, public awareness, advocacy work, and support for research. Our program tonight is being recorded, and it will be available for future viewing on our website at asthmaandallergies.org. All video and audio settings are turned off for attendees during the presentation. If you have questions during the presentation, please type them into the chat box, and if time permits, the doctors will answer questions at the end of the program. Before we begin, one brief disclaimer. Any mention or reference to a company, institution, or organization or its available products or services should not be construed as an endorsement or recommendation by AAFA New England. Information presented should not be used as a substitute for medical consultation and care to diagnose and treat specific symptoms and illnesses. AAFA New England will not be held responsible for any actions taken by attendees or viewers as a result of this speaker series talk, and the views and opinions expressed by the panelists are not attributed to their employees. Please allow me to introduce our panelists for our roundtable discussion this evening on disparities in our healthcare delivery system. Dr. Margee Louisias is a pediatric and adult allergist, immunologist, and a health services researcher in community-based interventions to reduce racial disparities in pediatric asthma. She is an instructor in medicine at Harvard Medical School and an associate physician and director of equity and inclusion in the Division of Allergy and Clinical Immunology at Brigham and Women's Hospital. Dr. Raolat Abdulai, board certified in internal medicine, pulmonary medicine, and critical care medicine, currently a global clinical lead in immunoinflammation therapeutic area at Sanofi. In this position, she is the clinical strategic lead on projects with a focus of bringing transformational medicines to patients with severe immune-driven diseases. She's also dedicated to increasing access to clinical trials for women and people of color. And Dr. Lakiea Wright, a board-certified internist, allergist, and immunologist. She is an associate physician at Brigham and Women's Hospital and has expertise in allergic diseases, asthma, and health disparities. Dr. Wright is also medical director of U.S. Clinical Affairs in the Immunodiagnostics Division at Thermo Fisher Scientific. And Dr. Jorge Rodriguez, a board-certified internist and Clinician-Investigator in the Division of General Internal Medicine and Primary Care at Brigham and Women's Hospital and Harvard Medical School. Dr. Rodriguez is currently focused on bridging disparities in patient-facing health technology, including patient portals and telemedicine. So welcome to all of the doctors, and let's begin. The first question is, what is a health disparity, to Dr. Louisias?
Thanks for that question. So let's first describe what is a disparity. A disparity is defined as a significant difference. And when we think about it in the healthcare context, that's differences in health outcomes, and usually it's by different factors such as sexual orientation, disability status. But for the purposes of this panel, and usually what's brought up in the literature is differences or disparities by race and ethnicity.
Thank you for that, Dr. Louisias. And I'd also like to add, when I think about health disparities, I also think about the CDC's definition, which places a heavy emphasis on the fact that these are preventable differences, often seen in socially disadvantaged groups. And as Dr. Louisias mentioned, there are many different groups, one of which can be low-income group or racial and ethnic minorities. And we have to remember that those are two distinct groups that can overlap, but don't necessarily overlap, and even high-income individuals from racial and ethnic minority groups can experience disparities due to racism and access or poor access to high quality care.
Okay, thank you, Dr. Wright. And when I think of health disparity, I think of disparities that can impact our actions or the actions we don't take. For instance, in the clinical trials context, such as not recruiting a patient into a trial because of implicit bias or assumptions about the patient's capabilities based on their race, ethnicity, or other characteristics. Or not ensuring that patients from a certain area, a certain population are recruited into clinical trials adequately, whether it's done deliberately or inadvertently. All of those are actions that lead to overall healthcare disparities.
I think everyone summed it up really nicely. I think what I'll add in terms of the work that I do, health disparities really come up in the way we deliver healthcare. So as technology plays an increasing role in healthcare delivery, the way I see health disparities is the way how people access these tools, whether it's having access to the internet or whether accessing to telemedicine or patient portals or mobile apps. Increasingly, we're seeing that patients from low socioeconomic status or racial and ethnic minorities are often less likely or have less access to these tools, and that not only kind of creates these digital disparities, but kind of down the line leads to the health disparities that my colleagues have so nicely summarized.
Thank you, doctors. The second question, we're going to start with Dr. Abdulai. What are the social determinants of health, and how do they contribute to health disparities?
Apologies, I was on mute. So so technically speaking, the social determinants of health exist really in 5 different domains or areas. So these are economic determinants, educational access and quality of education, healthcare access and the quality of your healthcare, your environment, such as your neighborhood, and also your social and community support. So roughly speaking, social determinants of health come in 5 discrete but also interchangeable categories which work to impact your healthcare outcomes and whether or not you experience health disparities.
Yeah, I think I think the sort of the downstream effect of this for a lot of our patients that don't have worse social determinants of health is really it impacts their healthcare outcomes down the line, and it's really sort of this kind of systemic or structural impact on these obstacles to care, and whether it's things like food insecurity or housing insecurity, really impact the way we manage our chronic disease it's really a big challenge, right? Because it's at different levels. It's not just like I can prescribe a medication and kind of make a patient better. It's really reflective of these kind of more system level challenges, and that's what makes them so challenging. Like for example, for asthma, we know that there's strong connection between poverty and low socioeconomic status, and developing asthma, worse outcomes, worse pulmonary function, worse symptom burden, more asthma exacerbations. But these are really hard. It's easy to point out that there's this neighborhood has poor food insecurity or poor food security, but what do we actually do about it? And I think that's where the challenge lies, and it really requires sort of an ability for us to step back as a society and say, how are our policies guiding and addressing a lot of these issues? What are some of the underlying factors that might be contributing to a lot of these social determinants of health? So ultimately, I think for me, it really reflects that it requires kind of this multi-stakeholder approach, because that's what makes it challenging. It's very easy for us to here's an inhaler for your asthma, but how do we address a lot of the things that are going on outside the clinic that we just don't see, right? We may see you for 15 or 20 minutes for your visit, but you're living your whole lifetime outside of that, and that's really where those social determinants come into play. And that's what makes it really, really challenging. And it really kind of makes us take a step back and say, like, as a healthcare system, we need to work with our community, with our policymakers to really address all of this going forward. It's a really, really challenging, complex problem, but definitely key to sort of addressing a lot of the health disparities that we've mentioned earlier.
Excellent, thank you very much. The next question, we're going to start with Dr. Louisias. What is structural racism and how does it contribute to health disparities?
Actually, I'll take that question there. When we talk about structural racism, Dr. Rodriguez and Dr. Abdulai talking about those social determinants of health. There's definitely a tie-in there, and so there was a very good article recently we're in the New England Journal in the December edition. Talking about the fact that there's no sort of standardized definition, but what we really need to recognize when we talk about structural racism is that it's beyond just sort of individual prejudice. It's more about how racism is embedded into our structures, meaning our laws, our policies, even our economic system and our cultural norms, and looking at, how do we dismantle that so that we can ensure that, we achieve, equity. And so it's, we'll go into more examples, but it's really looking at the policies and the rules and the practices and how that all plays into structural racism and perpetuates these health inequities, and looking at how to dismantle that.
Thanks for that, Dr. Wright. And I think one of the examples that we could bring up to really hone in on what is structural racism, because like you mentioned, it's a difficult concept to wrap our heads around. And so when I'm explaining it, usually I like to bring up the concept of residential segregation and really how that stemmed from redlining that actually was in the 1930s. And so redlining, for those of us who don't know, just a quick history lesson, it was at the time of the 1930s, these red line maps were actually created out of a federal policy to actually show risk areas for new government homeowners programs. And so basically what the HOLC ended up doing was creating these maps to basically categorize which areas that were more risky to for homeowners. And they denoted it by different colors. And so red was the most risky area. And it was red because it had the most amount of foreign people. It also had the highest amount of Black people as well. And basically the green area was the best. And so the other colors in between basically, were pretty much areas of risk in between the red and the green. And so what ended up happening was that the creation of these red line maps ended up leading to accumulation of both and outside of the red line areas, and also really affected the way we have funding and zoning of highway locations, school locations, and also the location of where we put our toxic hazardous dump sites. And so, over time, the policies that, led up to redlining and was essentially removed. We no longer do redlining. However, those structures that were created by the redlining maps are still in place. So unfortunately, we're seeing that. I want to think, just for the audience to think about, who is in your neighborhood. Think about the kids that go to your kids' school. Think about the racial makeup of your community. Really, this is all what we're seeing as a reflection of what happened in the past. And I think another great article that brings up some relevance for our asthma and allergy patients was actually in the Lancet. Actually, last year, they actually looked at some redlining maps in several cities in California. And they tied that to asthma emergency room visits and saw that the same way those red line maps were created, it correlated, exactly with those asthma ED rates. And so the areas that were actually in the red back in the 1930s had 2.5 more times emergency room visits for asthma relative to the areas in the green. So again, what we're seeing with, like Dr. Wright was mentioning, this is, there's no longer explicit racism. But basically what ended up happening with structural racism is that explicit racism ended up being structured into our community and reflected in these different health outcomes.
Thank you both. The next question is, what is the role of environmental exposures?
Yes, so that's a great question. Environmental exposures are great of great importance in terms of health disparities. And as you know, your environment, your neighborhood is one of the social determinants of health. And what we know is that minority populations, particularly in neighborhoods where there's a high population of Black and Latinos, are overrepresented in areas where there's poor air quality and where there's other types of pollution. And this is despite the fact that we've had the Clean Air Act, which has been in place since the 1970s and has been subsequently amended. We still have persistent environmental pollution, which leads to an impact on the health of patients. For instance, the pollution can be in the water, in the air, indoor pollution, or even in the soil. One famous example in the water is the crisis in Flint, where there are now criminal charges being brought up. The other would be such as air pollution, because there's a biomass plant that's going to be developed. I know there's some controversy here in Massachusetts and Springfield regarding this. As you know, Massachusetts is an asthma capital. It has one of the highest rates of asthma exacerbations and complications. And then another example is indoor pollution. Again, many people don't think about indoor pollution, but if you live in poor quality housing or housing where there's rodents and pets, that can lead to allergens that can trigger your asthma. And all in all, both the indoor and outdoor pollution, they can all lead to worsening health outcomes, more exacerbations, such as for asthma. And then obviously, when you have worse health outcomes, you also have higher morbidity, so more burden of disease and potentially even mortality. There was a paper done at Duke, it was in 2011, it was Miranda and Al, where they actually really wanted to measure this. So they said, okay, where are the highest density of population and what are the characteristics? And they found that the worst air quality, there was a statistically significant correlation between the areas with the worst air quality and the areas having a higher percentage of Black residents, a larger percentage of people in poverty, and even more younger patients. So you're more younger people. So this is impacting children and teenagers during the time when their lungs are developing when it comes to air pollution, and which can have long-term impacts when they become adults and could potentially lead to disease in middle age and as they age. So your environment is a huge determinant of health disparities. And we have evidence of this, and we are seeing more and more examples of further disparities, especially in areas where there's a higher percentage of Black and Latino and poor people who are residing in the area.
Yeah, I'd just like to add that, I think sort of 2 points here. I think one point is really around kind of, again, driving for policy changes and policies, similar to the Clean Air Act, where you really sort of highlight and address these issues at the more kind of systemic level and really kind of take into account who are the people that are contributing to this, or the companies that contribute to this pollution, where are they setting up, and having a better sense of how we develop those and making sure that the communities that they serve, so a lot of the communities that we've talked about here, are having a voice in those discussions, right? If someone tried to set up, something that was, very bad for the environment down the street from me, I might be a little bit concerned and speak up. But unfortunately, for a lot of our underserved communities, they don't have that same sense of empowerment. So I think working with those communities to really get a sense and empower them, and empowering policymakers to involve everyone in the conversation, I think is a huge step, because even I probably don't know what's going on all around my neighborhood and what's coming in and what's going out, where the pollutants are. I know I live by a small body of water here, and I'll admit I don't know, like, is it clean? Is it not? I don't know. And I think that's sort of one component in terms of just educating our communities and being able to drive those policy changes. The other thing to note, I think, in terms of, there's this whole movement around sort of patients having, access to their data. I think there's some component where we can kind of zoom in a little bit and really focus in on patients having access to that data, and having a more of a local sense of, like, either you sort of know the bodies of water near you, or even just like the air quality for that day might be beneficial to know, and making that a little bit more accessible to patients, and even in the clinical setting, highlighting that a bit more. I know as a hospitalist, I'm sure my asthma colleagues along here, we do this a lot better, but as a hospitalist, that's not something I sort of speak to patients about when I'm discharging them. I don't tell you, like, oh, your asthma exacerbation happened and it might have been because of this. Like, why don't you keep closer track of that? I'll talk to them about a lot of other things, and their inhalers and their follow-up visits. So that's one thing I think that we can bring into the clinical setting to really encourage our patients to understand a bit more about how their environment impacts them, so that they can feel empowered to say, like, oh, there's this high allergen, high pollutant date coming up. I have to be more aware that I might have my rescue inhaler a little bit closer to me, or just be more aware of some things that may come up. So I think there's a lot of power in that. And there's a lot of kind of fancy digital sensors that can kind of help support that effort by measuring some of the allergens and the pollutants in our environment, and making our patients feel a bit more empowered about knowing what's going on around them, both indoor and outdoor. With the indoor piece, which I thought was a really great and insightful point.
Thank you both. The next question is, what is the role of nutrition in the development of asthma and allergies, and what role does food insecurity play?
Yeah, so I'll take that question. So, we've been discussing sort of modifiable risk factors, and nutrition, looking at nutrition and nutrient intake presents an opportunity to sort of see, what are you putting in your body, and how can that potentially affect development of asthma or asthma outcomes. And so if we look at the data for asthma, we do see, for example, studies on vitamin D, and we know that vitamin D is immune modulatory, meaning that it affects the immune system. It can be antibacterial, antiviral, anti-inflammatory. And we know that asthma is a lot of inflammation, and so because of those properties, and because many Americans are deficient in vitamin D or have low vitamin D levels, we do see a signal or some evidence to suggest that repleting your vitamin D level can help reduce the risk of exacerbations, especially those triggered from infections. And so, and perhaps it's mild to moderate asthma. We have less data on severe asthma, and that's sort of one example, in that field or body of evidence is still sort of evolving. And then we can look at other things. Some colleagues and I wrote a paper about 3 years ago, published in the ATS Annals, about sugar sweetened beverage intake and development of asthma. And so we looked at in our cohort, the Project Viva cohort in Eastern Mass, of pregnant women and then their children, and followed them. And we saw that increased sugar sweetened beverage intake during pregnancy, and then also those children then in early life, about age 2 or 3, having increased sugar sweetened beverage intake correlated with greater odds of developing asthma. So I think that this is an area in which we really need to sort of do more investigation, and it's likely a balance of sort of having more intake of antioxidants and vitamin D, and you can think of antioxidants as sort of fighting that oxidative stress. Think about eating the whole rainbow of fruits and vegetables, and then trying to minimize your intake of things that can be inflammatory, such as sugar. And we see a lot of data for in diabetes and heart disease and fatty liver disease, that, sugar does have harmful inflammatory effects. And so we need to investigate this more, and it ties directly to that, structural racism and social determinants of health, because access to food, access to healthy foods, in many communities of color and low income communities, there's a lack of access to healthy foods and grocery stores that would have a wide variety of fruits and vegetables. And so we need to take all of this into consideration when we're developing, policies and doing city planning. And so there's also, a role in food allergies and the role of food intake, but I'll let Dr. Louisias talk a little bit more about that.
Oh, thanks for that, Dr. Wright. And I think, what you're alluding to with the idea of the food deserts, I mean, really, again, ties in nicely into the issue of food insecurity, because I think it's an area that's also really under-recognized in food allergy, and, when you think, well, just to define it for the group, food insecurity is really a household's inability to provide enough food for everyone to be healthy and to have adequate nutrition. And in terms of the scope of the issue, like before the COVID-19 pandemic, it was thought about like 10% of households actually had food insecurity. And now with the COVID pandemic, with people losing their jobs or being like underemployed, it's about 25% of households. And then when you break it down by race, like again, looking at those health disparities, Black and Latinx populations are 2 times that of white populations. And so if you can imagine that now you have a condition like food allergies, where the gold standard, unfortunately, right now for treatment is avoiding foods. And then you combine that with food insecurity, where you don't have access to enough nutritious foods, to be healthy. I mean, this naturally is going to end up leading to a disastrous situation. And so I think the idea right now is that, what ends up happening when you have the intersection of these 2 issues, what these families are seeing is that these families with food insecurity, they're having access to food pantries, where these food pantries are not even knowledgeable in food allergies, right? Or if they're on public assistance and receiving, WIC or SNAP benefits, they may not be able to get the different types of, safe food allergen-friendly foods, or they may not even get it in the appropriate quantity, like if that food is available, on their public assistance plan at a certain size, if they find it in a different size, they can't even get that food. And so I think one of the papers that I thought that really highlighted this intersection, and really there's frankly a dearth of literature, but there was like one paper that I saw that came out of Arkansas Children's Hospital, where they looked at their food allergy patients and asked the question, how many of you are actually experiencing food insecurity? And they saw about 20% of their patients experience this. And I think, for those of us who are allergists in the group, or even for our food allergy patients watching, I mean, have you been asked that question if you've experienced difficulty, getting food? And I think we're not doing a good job of, assessing that. And I think really, thinking about, at the end of the day, with the goal of this panel, thinking about solutions. I mean, I think the one thing is increasing awareness. Like if we don't ask the question, we're not going to know that it's a problem, right? And then I think another thing just to put on the table in terms of an actual action item is looking at, WIC, for example, and having them, reduce brand and size restrictions on the type of WIC allowable foods, and really having that being accessible to states. And I think another organization that, some of our viewers could, look into that, does a lot of great work in this area is the Food Equality Initiative. So, they do a lot of great work, and I think they should be definitely further supported.
Thank you. The next question, what is the digital health equity and how does it contribute to health disparities? And what can we do about it?
I'll take a crack at that question. So, I think the understatement of a lifetime is that our lives have changed significantly in the past year. And so this includes the way we receive healthcare. Healthcare has gone from being in the office, physically being in the office, to being delivered via a cell phone or via a computer screen. So it's gone mostly to telemedicine for many patients and their providers. However, this has led to a new category, or maybe a category that transcends multiple domains of social determinants of health, which is the digital health divide, which is both an economic issue. It is also a neighborhood issue or an environmental issue. And here's why. We know that with this digital divide, some people may not be able to get healthcare via telemedicine for several reasons, potentially due to lack of the infrastructure in their neighborhoods. Maybe their neighborhoods do not have the Wi-Fi infrastructure for them to be able to have a good connection, and so they have poor internet connection that doesn't allow them to be able to take full advantage of the opportunities available with telemedicine. Or economically, they may not be able to afford a computer, a good working computer, or even a smartphone where they can have this ability to communicate face-to-face with their provider via telemedicine. They may not have the economic advantage of being able to purchase these wearables, such as an Apple Watch or some other smartwatch or smart device that allows them to be able to electronically monitor their vital signs or keep up with their health. Furthermore, they may not be able to pay for apps that allow you to access even higher level of care, a concierge type of care. So actually, this new digital realm that we're in opens up more opportunities for health disparities, so widening the gap in health disparities rather than narrowing the gap in health disparities. And so we do see that with COVID, we've seen the opening of new areas where work needs to be done in terms of providing access to patients and providers in order to be able to deliver good quality health care that can be sustainable.
Yeah, those are great points. I'll add a few things here. I think that the way I kind of break it down in my head is sort of this kind of like access, adoption, and kind of action around digital health. And we touched a good amount around access to different types of technologies. I think the only other thing I'll add, in much the same way that in the sort of like real estate world, there was the digital there was redlining. In the same way in the digital space, there's a concept of digital redlining, which really reflects the fact how internet service providers, so who you get your internet from, offer their internet offerings, so the service that you get. And there's some data to show that in certain underserved areas, or those areas were often getting kind of slower speeds at higher prices, which obviously is not great. So there's some component of kind of structural or systemic issues driving some of these digital divides. I'll note that. And then in terms of sort of adoption, it's really sort of this concept of, if I give you a phone or a computer and I give you the internet, does that mean that you're going to be able to like log on and be super savvy and do all these things? Like the reality is no, right? There's sort of that gap of like digital literacy. There's that component of being able to meaningfully engage with the tools that you have. And I think that's one of the more challenging pieces, because even though we may be able to get devices or internet to patients, it's another thing, when you're 2 minutes, your visit is 2 minutes away, you have to navigate your telemedicine platform, remember your password, or remember your email. All these kind of different steps you have to take in order to kind of engage in the telemedicine visit is sort of a gap that I think we're still actively working on, and probably requires a sort of either the healthcare system themselves taking on things like a digital health navigator, which specifically supports patients in using a lot of these tools, or working with community organizations like libraries who've been kind of working on this for a bit. The other thing I'll say, this has been mentioned in the past in terms of kind of access to clinical trials. Similarly, there's some data to suggest that there's some level of bias that comes into play into who gets offered these tools, right? I think we unfortunately in our system sometimes make our own bias is going to say like, this person doesn't look like they'll be able to manage like, the video or the app. I'm not going to offer it to them. But in reality, like we don't know. I mean, just anecdotally for me, I know there's plenty of my family members who I've been surprised by how kind of savvy they are with a lot of their technology. Maybe not in the healthcare space, but they're using WhatsApp to like text their family members in Colombia, and I'm like, whoa, I didn't even know you could do that. On Stella. Wow, this is impressive. And so I think having those considerations and as we're kind of approaching this, and really having a conversations with patients from that perspective to offer to everyone. I think kind of zooming out a little bit, I think there's some policy efforts that can really drive this. I think cost, as Dr. Abdulai mentioned, is a big thing. I think there's some argument to make that we should make internet access much like other social determinants of health, like key social determinant of health, in that way that we provide support for it. And I know in the latest COVID kind of relief package, there is a policy that offers certain populations, I think it's like a $50 reimbursement for internet. It's only, I think, for like 6 or 9 months or so, but that's sort of a move in the right direction and trying to make the case that if we're really delivering healthcare across these technology platforms, we really have to develop these tools and offer it to everyone and provide all the kind of the support in much the same way we have sort of WIC and SNAP and all these other things for food insecurity. Why don't we apply similar thinking to this?
Thank you. Next question. What is the role of genetics in health disparities as it relates to asthma and food allergies?
Take a crack at that one. So this is definitely an area that is really debated and argued over. But I think just to put out there, there's a really huge misconception about the role of race. Race has no biological underpinning. Race is what we call a social construct, so meaning that it has social implications. So, for example, the color of your skin, so how much melanin you have, really affects the way you're treated and really affects the way that you're perceived by others. And I think what complicates it and why sometimes people tie it into biology sometimes is because of its impact on health outcomes. Because the way you look will affect the way others treat you. So, through explicit racism that we brought up before, even if implicit racism, meaning like, microaggressions, or, is someone giving you eye contact, or, like even what Dr. Rodriguez was mentioning, even like being offered, an option to be in a clinical trial or be offered something, or not. And so that ends up tying into health outcomes. And so literally the amount of melanin in our skin does not change our biology. It's really, our health outcomes are changed by the way we're treated. But I do think what does complicate things a little bit too, with, just going back to the structural racism thing that I was bringing up before, is that, we do know that our genes can be modified by our environment, something called epigenetics. And so that basically will affect the way certain genes are expressed or not expressed, for example. And so if you tie it back to that structural racism, theme that we've been bringing up, and what I brought up too with the redlining issue, if you think about the issue of that racial segregation and, a certain racial group being in a certain area and being exposed to certain pollutants, for example, because of where they're located, they may have certain genes that are going to be turned on or turned off because of that particular exposure. And on the surface, it may look like, oh, this racial group has this particular type of biology because of, just because of their race, but it's really ties back to the issue of that exposure really causing the genes to be, expressed in a different way.
Yeah, and I'll add to that, it's really important that we have studies that look at this in a very careful way, to sort of, tease apart that relationship, looking at the gene and environment interaction. And so if I think about, the work that's being done by Dr. Esteban Bouchard out of UCSF, he has one of the largest groups of minority children looking at their gene and environment interactions and looking at asthma outcomes, and he really has really robust data looking at, tobacco smoke exposure, air pollution, looking at responses to medication, socioeconomic status. So really robust data to sort of further investigate that gene environment interaction. And it's very important that we have that sort of representation so that we can understand those correlations better.
Thank you. The next question, why is it important for communities of color to participate in clinical trials?
That's a great question. So the most important reason for communities of color to participate in clinical trials is so that we can make better drugs. And these better drugs are for everyone. And so that is the number one most important reason. But there are a lot of barriers to participation in clinical trials. I think number one barrier that I'll come back to is mistrust. But then there are other barriers in terms of participation to clinical trials. This includes competing demands. Again, since clinical trials for many people are optional, if it's not convenient, or if it's the clinical trial site is located somewhere far away, and they're not able to get to it, it can be a barrier to participation. Their fear of potential safety effects, and I know that for some people, this is a fear that some have expressed regarding the COVID studies. There is also stigma sometimes with people being in clinical trials, especially for clinical trials as it relates to mental health. There can be a barrier to clinical trials. For instance, if there's any legal status question for some of your family members, and providing that additional information in the clinical trials, you have a fear that there could be repercussions for your family members. But most importantly, there's a lack of access to information from clinical trials because of the implicit and explicit bias in the healthcare system, where people of color are not being offered clinical trials at the same rate as their Caucasian peers. But going back to mistrust, I want to talk more about this because there's a history of mistrust when it comes to clinical trials. And one study that many people point to is the Tuskegee study that was done. And in the study, men who had syphilis were recruited into the study and monitored for years, decades actually, to assess the evolution of syphilis, despite the fact that during that time, a cure was found, basically, which was penicillin. And so there were trials related to Tuskegee. And in fact, we are at the 42nd, I believe, anniversary of the Belmont Report. The Belmont Report was really triggered by Tuskegee and other incidences of wrongdoing in clinical trials in order to, number one, research what happened, why is this happening, and then what can we do to improve, to make sure something like Tuskegee never happens again, and to make sure clinical trials are safe and equitable for all people. And from the Belmont report, there were three basic principles that came out, three initial basic principles of clinical trials, and that was respect for persons, so really providing informed consent so that the person, individual who's going to be participating understands everything that's going on and can make that decision about whether they want to participate. There's also beneficence, so making sure you weigh the benefits and risks of the trial for the patient, and it should, in general, should weigh towards benefits. And this is what we want for all drugs or all trials, drug and non-drug. And then justice, meaning there should be some fair and equitable distribution of the benefits of the clinical trial, and no one group should be unduly burdened. For instance, prisoners, you shouldn't test on prisoners. Number one, because they're a vulnerable population, but then you shouldn't unduly burden communities. And so since then, the industry has put together guidelines, and there's many regulatory guidelines regarding conducting of clinical trials, but the mistrust still persists in many communities. And so this is why we end up seeing lower rates of communities of color, patients from communities of color enrolling in clinical trials, in addition to the implicit and explicit bias in healthcare where principal investigators, coordinators, or even referring physicians aren't telling patients about clinical trials, or think, for instance, with an African-American patient, oh, they won't understand and it will take too long to explain everything. So we're just not even gonna try to see if they're eligible for this trial. That creates health disparities, but most importantly, it creates a skewing in terms of the population that's represented in the trials. And this population may not be reflective of the population that may eventually be treated. So it's very important for us to have a diverse group of patients in our clinical trials, because eventually we can use that to make better medicine. And just so last note, I think we have to shift in terms of the way we look at clinical trials. Just like blood donors and organ donors, people who participate in clinical trials are heroes. They are, they're going in to help with an investigational medicine. Sometimes it could be a non-drug or digital tool, but they are really pioneers in this area. And we should have as much respect as we do for blood donors and organ donors for patients and people who participate in clinical trial, because it really helps the greater good and it provides for the public health. And I speak in particular for those people who have been participating in COVID trials, because this and the results from all of these trials is going to benefit the greater good, the public health, and help us hopefully get out of this crisis. So thank you.
Thank you. The next question: how do we eliminate health disparities? How do we achieve justice? And what's justice versus equality?
Yeah, so I think this is, so going back, I can take this first since I just finished speaking, but just going back, the first thing is we need to acknowledge. The great thing about what has happened and how clinical trials have evolved is because there was acknowledgement of the wrongs, and there was acknowledgement of the issues in the system, and that was through the Belmont report, as well as other reports. And so I think the first step for us to be able to actually do anything about these health disparities, we need to first acknowledge where the issues exist, and then we can create solutions. But acknowledgement is the first step in being able to tackle the problem of health disparities.
I think I'll add that, a key step to this is really, I think, as a healthcare system, acknowledging that we don't have all the answers. And I sort of both say this and practice this even when I'm on clinical. I often rely on my patients and more broadly on the communities that are facing these challenges for solutions, and really being collaborative about the way we go about it, and acknowledging the fact that we as a healthcare system don't have all the answers. And there's a lot of great creative solutions out there in our community that have that may have already been developed, and then in some instances we already know the answers of what we need to do, and it's a matter of either policy taking role or using concepts from implementation science to kind of implement the right thing. But I think ultimately for me it's really about going back to the communities that we're trying to help and trying to engage with, and really working collaboratively with them to come up with a lot of these solutions to make sure it's actually solving the issues that they're facing, rather than sort of coming in and saying, here's what we're going to do and here's what we're going to solve this. I think this sort of this kind of community-based approach can really, really address a lot of the health disparities that we're seeing.
I would agree as well. I think, Dr. Abdulai, as you mentioned, sort of the acknowledgement of the disparities. COVID has placed that sort of a magnifying glass on it. We knew that the disparities were there, but now they're really like in the forefront, sort of in our face. And then Dr. Rodriguez, you were mentioning how we need to work with, with community members to come up with the solutions. And I totally agree. I think that, on an individual level, we should empower patients, about and educate them about, different, health conditions so that they know how to advocate for themselves. And then when we look at solutions, we have to, involve patients in offering up those solutions. And we have to work together and sort of transcend that sort of individual level to work collectively to advocate for policy reform. We have to elect, government officials that are going to, create policies that eliminate these, inequities. The elimination of the inequities have to be in the forefront, and we have to involve patients as well as key stakeholders to come up with those solutions and really have the policies be reformed and work with patient advocacy groups like AAFA to sort of really push that agenda forward. And I think, we can really make a difference with combining those initiatives.
I guess that leaves me. I thought you guys did a really good job, explaining really what we need to do in regards to eliminating or abolishing disparities. And I think what I could add is really at the end of the day, the solution is the principle of justice. Because, usually, you'll bring up the principle of equality, like we want equality, but really that's insufficient because that's really just the equal distribution of rights and opportunity, and really that's, again, not enough. And equity, is a good goal as well, because with that, we're distributing, those rights and opportunities based on the need, but justice just takes it to the level of we're really getting rid of that foundational issue or those structural issues. Through, typically through, different policies and kind of legislative type of matters to really get at that underlying issue so that we could really have that fair distribution of rights and opportunities. And I think the way we have to think about this, because sometimes when you look at it and through that lens, it can really feel overwhelming, like, oh my God, how are we going to fix this problem so huge? Because, we see disparities not just in asthma and allergy issues, we see it across every single health condition. So, it seems like a lot, but I think, we have to really look at this like a all hands on deck approach. It's going to be, what are we doing as individuals in our own local communities? What are we doing federally? What are different institutions doing? Like, for example, academic medical centers, what are schools doing? So I think everyone has to feel like they have skin in the game to be able to really think about what changes they can make. And I think with that we'll be able to really lead to, eliminating disparities across the board for everything.
Thank you. That was the last planned question. But we do have time. There was one question in the chat from an audience member from Dr. Barnes that I'd like to pose to the doctors. She said, you have to limit how much vitamin D due to being a fat-soluble vitamin. Does your gut health affect your asthma or development of food allergies?
I could start with that one a little bit. Thank you for that question. I mean, I think right now, what you're getting at with the gut health, I'm assuming you're probably alluding to the issue of the microbiome. Fortunately, with the way our format is, I can't, see your face to be able to get that. But I think the idea is that, this area of research is really evolving. We actually, in our group here at the Brigham, had some recent lectures by people out of the Channing who do a lot of work in this area. And I would say that we just don't know. I mean, I think the idea is that obviously, There's been a lot of work looking at the role of, the different types of organisms that are in your, in your gut microbiome, and the different amounts of them, what we call genetic, the microbiome diversity, or even the different groupings. But at this time, it's really unclear, really is that microbiome, does it lead, the different types of organisms, does it lead to asthma and allergies, or does the asthma and allergy issues actually lead to these changes in the microbiome? So we don't really know, like the chicken and the egg. I think there's going to be definitely more work that seems really interesting that I've seen that kind of plays a role in just figuring out the association, but I'm not really, I think we don't really have a clear answer at this time. But I think overall, just being a healthy person is always going to, lead to better outcomes. But at this time, we don't really have any clear evidence either way.
And what I'll just add to that, because it applies to sort of vitamin D and what Dr. Louisias was saying about, having a balanced diet. So we know that probably as Americans, we don't eat enough fruits and vegetables, and we know that Americans tend to stay indoors, so there may be a fair share of people who are deficient in vitamin D, but it's not that sort of like one thing would give you the answer. It's more about having a balanced diet could be helpful, but it's really a discussion to have with your actual provider. And I think AAFA even has some good resources about vitamin D intake and the connections with asthma that we could also share. That would be really good to read as well.
Thank you. Thank you all. I would like to thank the doctors for tonight's presentation. And my notes just went away, so let me just get that back. Here we go. So I'd like to thank the doctors and also for being available and being able to host this right after Dr. Martin Luther King Day. And I want to thank GlaxoSmithKline for their sponsorship of tonight's speaker series event. AAFA New England has some events coming up in February. We have a concert by Kyle Dine on February 13th at 2 p.m. on a Saturday afternoon. And we will also be mailing out our winter bulletin, which will include the second part of a two-part series by Jackie Rodriguez-Lewis on disparities in the healthcare delivery system as well. Also, we will have an article from Dr. Michael Pissner on infant anaphylaxis. So you can look for those things in February. AAFA National's Asthma Capitals report that you're looking at now, the top 100 metropolitan cities that are most challenging to live in with asthma. The ranking factors in several asthma outcomes, risk factors that can influence asthma outcomes. This has identified 2 asthma belts, one along the northeastern seaboard and the other through the Ohio Valley. Springfield, Massachusetts, as was mentioned by the doctors earlier, continues to take the spot because it has a high asthma rate overall, and it has the highest number of asthma-related emergency room visits. You can find the report and more information at asthmacapitals.org. In 2020, AAFA National released an update to their 2005 Asthma Disparities in America report. The report highlights 69 strategies in 4 main areas to address general health disparities and specifically for asthma. AAFA National remains committed to taking bold actions to facilitate significant improvement and building collaboration with federal, state, and non-governmental entities and individuals who share the similar goal to save lives and reduce the harm and unequal burden of asthma on underserved groups. You can read the full report at aafa.org/asthma disparities. And AAFA New England invites you to join us online at asthmaandallergies.org. There you will find all the information you need to sign up for future events, to join our mailing lists, become a member, or to make a donation to AAFA New England. Your support makes possible our pursuit of life without limits for people and their families affected by asthma and allergy conditions. And again, thank you to the 4 wonderful doctors that gave us their evening tonight. And thank you for everyone who attended. I hope you all have a wonderful evening. Good night.